Next presenter, Dr. Ashraf, is going to be talking about the sliding toward extremis.
All right, thank you everyone for having me. Thank you for the committee putting this together, faculty for being here. Dr. Ashraf Hassan from University of Florida, like the other two that were on before me. So let's get started. Starting with our case, the HPI is a 63-year-old gentleman, no prior cardiac history. He's actually out of town visiting his daughter. They're out, they were both shopping actually. She came back to the car and she found him agonally breathing. CPR was immediately started, EMS was called. They arrived shortly, finding him in VFib. They gave him about 3 shocks and achieved ROSC in the field. Downtime is estimated to be 10 to 15 minutes. Upon arrival to the ER, he is immediately intubated. Vitals appear relatively normal. This is right after he got whatever epi and all that in the field as well. His labs, initial labs show really high lactic acid, relatively normal creatinine, unknown baseline, and then a high sensitivity troponin that wasn't super impressive either. And his initial EKG that they got doesn't show any ST elevations, any signs to suggest acute ischemia. Nonetheless, VFib arrest, we take him to the cath lab, and as you can see, he has this filling defect in the proximal LAD, but it does show good distal flow. A PA catheter is also placed while he's in the cath lab. As you can see some of the pressures, he has a very narrow aortic pulse pressure, 88/73, map of 81. Wedge is also relatively narrow at 38/23, mean 28. RA pressure is elevated at 14, wedge is elevated at 21. He does have a low cardiac index, 1.7, otherwise relatively normal-ish SVR and PVR. Due to concerns for electrical instability, the coronary intervention is actually initially deferred, and instead he has an intra-aortic balloon pump placed, and he's medically treated. He is sent up to the CCU, and over the next several hours, he continues to require escalating doses of norepinephrine, vasopressin. Lactic acid continues to rise as well. And so he's taken back to the cath lab since he's not doing well. And there his intra-aortic balloon pump is replaced with an Impella CP. And his LAD lesion is treated at this time with thrombectomy and angioplasty. Of note, at this time, he was electrically stable, so he didn't have any more VTVF. Here's just a second angiogram that doesn't play quite well. So here's just a comparison of his hemodynamics with the balloon pump and the Impella. As you can see, the Impella, the map is a little bit lower than it was with the balloon pump. The combined output, though, is also relatively similar. The cardiac output of just looking at what the heart's doing with the Impella is markedly lower, and power output is also low. The EDP is lower, and with that, then the calculated coronary perfusion pressure is higher. And this kind of highlights why an Impella is used in these cases in AMI shock and why it's so helpful and why the changes we see in outcomes. So just a discussion of what we see here as we the definition of cardiogenic shock kind of highlights the downward spiral of shock, which is you get this myocardial ischemia, decreased cardiac output, you get vasoconstriction, increasing afterload, increasing myocardial oxygen consumption, worsening ischemia, and it keeps going downwards. And our goal is to stop this spiral and reverse it. And another important difference between AMI shock and cardiogenic shock of an acute on chronic heart failure patient is that unlike an acute on chronic heart failure patient who's remodeled that rightward shift on that PV loop to increase end-diastolic volume, an AMI shock doesn't have that same remodeling, and they might not respond the same way to the same therapies you might use in someone who does have acute on chronic heart failure. Just as a recap of what we learned this weekend, a balloon pump decreases the afterload, which can increase stroke volume. All you have to do is find the super responders, a simple task. Whereas a peripheral VAD and Impella directly unloads the LV, decreases the area of the PV loop, and it decreases cardiac work as well. Something to mention about vasopressors, as we noted in this case, there was an increasing use of vasopressors. That in itself is a bad prognostic measure. Increasing vasopressors is associated with increase in mortality. Inotropes increases infarct size in AMI, which has been shown in prior old studies. And there's some animal models from back in the day that do show that coronary circulation is sensitive to these alpha-1, alpha-2 agonists, and increasing doses of norepinephrine can lead to some coronary vasoconstriction, which can then worsen microischemia, cardiac dysfunction. And so while an intra-aortic balloon pump increases coronary perfusion pressure by increasing the diastolic blood pressure, a PVAD, peripheral vein Impella, although the diastolic blood pressure is modestly increased, it's that decreasing the LVEDP that really improves the coronary perfusion pressure, and you see that robust change and outcomes with it. So the goal, for us treating cardiogenic shock, the goal is to decrease mortality, and do that. We want to wean vasopressors using mechanical support, and we always want to choose the correct device for the correct patient. As we've learned this weekend, we always want to sometimes use the best thing that's the smallest intervention possible, as everything we use comes with its own risks. Otherwise, everyone would be put on an ECMO or something like that. AMI versus acute and chronic heart failure. With AMI, you always want to revascularize and perfuse the coronaries, rest the heart. Whereas with acute and chronic heart failure, you kind of want to tip the patient back, and sometimes all it does take is an intra-aortic balloon pump. As we've seen, they respond quite well to it, and then talk and think about advanced therapies. Whereas in an acute MI patient, they may just recover, as we've seen with other cases today. So in summary, cardiogenic shock complicates about 10% of all MIs. For out-of-hospital cardiac arrest, there's no difference in 30-day mortality between immediate and delayed angiography. The use of PA catheters prior to MCS is associated with lower in-hospital mortality. PA catheters provide invaluable insight for medical decision-making, and they should always be used. Intra-aortic balloon pumps offer modest output on its own, but can augment cardiac output for a subgroup of patients that are known as super responders. Careful patient selection with knowledge of their physiology allows for thoughtful decision-making on which mechanical support device to go for. An Impella unloads the ventricle directly, and for patients who are transitioning from the stage D to stage E, despite mechanical support, increasing vasopressors, you have to revisit the hemodynamics, and as shock is constantly evolving, we have to be constantly thinking about what the next step is and how do we get these people out of that downward death spiral. And some closing remarks. It takes a village and a foundational knowledge of hemodynamics to manage these cardiogenic shock patients.
Dr. Ashraf, thank you. A few comments just related to your presentation, as well as the others. That the panel is very sensitive to the fact that these are multidisciplinary decisions, and typically the final decision is made with somebody, a woman or a man who has more gray hair than you do today. So you're put in a position of defending a position that a group made, and so we're all sensitive to that. I have a question for you regarding this. The initial strategy was to defer an intervention due to arrhythmic instability. What was the thinking there? Because other people could have said perhaps that we should unload the ventricle, and that's actually the ideology, and so starting things like norepinephrine would only make it worse, not better.
100% agree. So initially when he came into the cath lab, he was not on any vasopressors. And the initial decision, I'm not an interventionalist yet, but so the initial decision, I'd love to hear what the other interventionalists think, was to defer, and the explanation that was handed kind of on sign-out was that there was good distal flow, and the risk of maybe inciting more electrical instability with ballooning the proximal LAD at the time was something that was wanting to be avoided, and instead the thought was maybe just getting an intra-aortic balloon pump in to give some coronary perfusion and rest the heart would be enough. What instead happened was ongoing worsening of the shock. Essentially, lactic acid was rising, and I think the initial one was 7, actually went down to about 3, and then it started climbing back up again. Vasopressors are being increased, and so this is a dynamic thing where we call the interventionalist back, a different operator is actually on at this time. It's like shift change, and so a different plan of management is used instead.
Now, what do you think was the origin of this electrical instability?
Yeah. So that proximal LAD looked funny, and I think that was maybe an acute thrombus that had some, revascularization of it on its own. And so I think in the field it might have been more like an acute MI that by the time he came to us, he had enough distal flow that we didn't see the ST elevations in our ER, even though that had only been about 20 or 30 minutes.
But I'm a cardiac surgeon, I'm not a cardiologist, but somebody who came with a BFib arrest is a marker for acute MI, is a surrogate for STEMI, so maybe the panelists can
Dr. Ashraf's senior is not here. Can anybody support this position or provide some additional insight? It's not really fair. That's what I was kind of alluding to, is y'all are kind of put on the spot here a little bit. It's supposed to be educational and non-Socratic.
Yeah. I mean, I can't really support it. I just wonder what they were thinking. You have an arrhythmia. You have substrate for ischemia. I don't know why you put that together into ischemic arrhythmia. And if you do, then it's not quite clear what you gain from waiting on this. So it's just as likely that you will exacerbate the arrhythmic substrate by leaving it alone, and that you will make it better. Jim Burke is going to tell you.
Yeah, would we all not agree that we actually learn more from our mistakes than the cases that go perfectly?
Agreed.
Yeah.
Please.
I wanted to follow up on that too, because my question was, you made a very nice point about looking for super responders with balloon pump. You had a patient come in with an unstable lesion. He was in cardiogenic shock with a lethal dysrhythmia, and elected to use balloon pump support to rest the patient. What is your protocol for evaluating the quote unquote super responders and then deciding about escalation of care?
Yeah, so from my experience at our institution, what we learned is that that's not the patient that's going to be the super responder. The MI patients are the ones that do need the impulse support, as they don't have the remodeling. For someone who doesn't have cardiac history, presumably had a normal EF and was living a normal life, this person's heart is not ready to just have a little bit of that afterload reduction, and all of a sudden you see that PV loop shift and his stroke volume increase. The ones that we see as the super responders are the ones that are walking around class 2 heart failure, EF is 10%, maybe they had a Thanksgiving dinner too many or Christmas or something, they ate too much salt, and they come in tipped over, and they live at an index of 1.8, but now they're in cardiac index of 1.1, they're breathing heavy, they do have a lactic acidosis. Those patients respond remarkably well to balloon pumps, and within a day or two they open up, diurese, and you shift them over. Sometimes this is a point where they need ambulatory inotropes or whatever, but those are the patients that balloon pumps really show that benefit for. And so those are kind of, in my mind, the super responders, the remodeled hearts, the chronic heart failure patients.
Yeah, just a couple of comments. One is, these are the cases that get reviewed at CATH conference and everybody has an opinion. I can give one excuse for why that the patient was pushed back, and that's the NCDR, which is fairly unforgiving in a patient who may have unknown neurologic outcome after a cardiac arrest. I don't fully believe that we should follow that, but the metrics are fairly harsh when your mortality statistics are reported. I still probably would have gone ahead, and I'm sure your attending's partner, who had to come in later on, was all that excited about having to do that as well. But I do, between the tomahawk and the coact and a few other things like that, he didn't have obvious ST elevation, although he did have a lesion. The question is, you took him to the lab anyway. So either you don't take him to the lab or you take him to the lab. That's sort of the issue. I do give you credit to getting the right heart catheter in and having those hemodynamics, and then secondarily responding quickly when he was deteriorating. So, but the NCDR and the metrics that are publicly reported tend in many places to change people's practice where we may not do the optimal thing for the patient. Thank you.
Thank you. Thank you, everyone.
Thank you.